Good afternoon, everybody. This is Avash Kalra. I'm the course director and one of the transplant hepatologists at University of Colorado. As more folks join the webinar, we'll just start with some introductions before we get started. So first of all, thank you to everybody for joining. This is the fourth webinar out of five for this calendar year, and the remaining lecture will be in November, and the information for that will be sent out at a later date. It's also worth noting that the videos for all the past talks are on the website as well. But to get to the topic at hand for today, Dr. J.P. Norvell, who's a colleague of mine, he's an associate professor of medicine and a transplant hepatologist here at the University of Colorado, also the program director for the Transplant Hepatology Fellowship, is going to give today's lecture on the management of alcohol-associated liver disease. JP, thanks for joining us and giving the lecture today.
Thank you, Avash. Thanks to Avash, Christy, and the department for inviting me. I hope you'll find today's lecture to be enlightening, and this is certainly a pretty bread and butter topic. Not to say it's not important as some of the esoteric lectures, but this is something we see every day. And in fact, this morning I had my transplant evaluation clinic, and I found myself literally telling patients things that I will be repeating here during this hour. First of all, here are some of our disclosure slides. I have no pertinent financial relationship disclosures, but I always take this opportunity to disclose that I am a mere hepatologist. I'm not a transplant social worker or transplant psychologist, nor do I pretend to be. Well, that's a lie. I do all the time with patients, as I try to emphasize, but I think a big point of this is the need for multidisciplinary approach to these patients, which really involves lots of different team members. We will be giving CME here as identified. Don't worry about taking that, using the QR code now. We'll show that again at the end to get your CME credit. So some of the learning objectives. One, we'll just talk about the burden of alcoholic liver disease and also define alcoholic use disorder. And I say that in the same sentence because I think a big point here is that these are two different but intertwined diseases that we need to address simultaneously in our patients. We'll define and also discuss management of alcoholic hepatitis and alcoholic liver disease. And we'll talk about the role for liver transplant, which is, I think, really the meat of what we're talking about. And we'll also talk about what role referring providers, aka you, can provide to our patients before, after, and during their transplant evaluation. So I always like to start with the case, and this is a case that we've all seen. In fact, I think I saw a patient exactly like this last week. 31-year-old. And if that seems young, it's because it is. And we're seeing younger and younger patients with alcohol use disorder, basically presents to clinic after a recent admission at another hospital. So just 2 weeks before, he was admitted with new jaundice, ascites, AKI, and of course had just stopped drinking a week or two before. As we hear all the time, he had just lost the taste for alcohol. He's really sick. While he was in the hospital, his billy peaked at 30. He had new AKI, the creatinine as high as 3.2, showing coagulopathy, and his MELD 3.0 score was quite high at 31 with an elevated discriminant function as well. And imaging suggests that he has underlying cirrhosis. So, the $1 million question here that we get asked all the time is he a transplant candidate? And the answer is, I don't know. Hopefully we'll discuss that. So let's back up first and talk about the overall burden of alcohol use. So worldwide, harmful use of alcohol is associated with about 3.3 million deaths, or almost 6% of all deaths overall. And this has really peaked in 20 to 39-year-olds at about 13% of all their deaths are alcohol related. Sober statistic here, no pun intended, about 380 people die in the United States a day related to alcohol use. So that means about 16 people statistically are going to die during this hour-long lecture. At the same time, about 2% of the general population in this country have alcohol-associated liver disease. Now, it's a very broad definition, even including just mere hepatic steatosis and going all the way to decompensated cirrhosis and alcoholic hepatitis. But not surprisingly, alcohol is the leading cause of liver-related mortality in the United States. And despite being over half of all the patients that we see with liver disease, it gets only about 5% of the research dollars of all research funding for liver disease. And as you all see on the front lines every day, the rate of ALD is increasing, with the largest increase in younger adults, females, and minorities. And this is a huge financial burden to our country as well. Currently 31 billion and estimated to cost at least $66 billion in the next 15 years. I should say the average hospitalization for a patient with alcohol hepatitis is around $50,000. So we also should talk about alcohol use disorder, which I'll refer to as AUD moving forward here. This impacts about 10% of all adults, and I really hate the statistic because it's including patients as defined as 12 years old and older, which is, again, quite literally sobering. So if it seems like this is increasing, it is. And as we all felt firsthand with the pandemic, when patients were now, and I shouldn't say patients, all of us, were now at home, oftentimes, but not working, had increased social isolation and depression. We saw the alcohol sales in the United States increase as 60% of patients increased their alcohol consumption. And this did not take long to translate into increased mortality. In fact, there was a 25% increase in monthly alcohol-related deaths within months of the pandemic beginning and the increase in alcohol consumption. And what's we hear, I feel like a lot more about the opiate crisis, but actually, at least here in Colorado, alcohol is now, in all causes, responsible for more deaths than opiates, but yet there has not really been public action. And there have been a lot of things from a policy standpoint that have been shown to decrease alcohol use and abuse, like, I hate to say this, but increasing taxes on alcohol that have not been enacted. And it's not just here in Colorado. Neighboring states, especially New Mexico, has seen an increase. This is one of my co-fellows published before the pandemic, that the biggest increases in mortality attributable to cirrhosis are in New Mexico, and especially in young patients. And we see this every day in clinic. Even before the pandemic, alcohol was the #1 cause of needing liver transplants. And so for a long time, we've been transplanting patients for alcohol cirrhosis. And I tell patients, including this morning in clinic, that a transplant will do a great job of fixing the problems related to alcoholic liver disease, but a transplant does not fix alcohol use disorder. So again, we need to address both of these issues simultaneously. And this data shows that any alcohol use really will impact the overall both allograft and overall patient outcomes. So alcohol use after transplant, unfortunately, is all too common, and this is data referring to patients that we historically transplanted for cirrhosis. About 15 to 35% will at least have some alcohol use after transplant. And of those that are considered harmful or excessive drinking, there's which is a minority, but a very important minority, about 2/3 of those patients will die. And the median time from diagnosis of allograft cirrhosis to death is a mere 1.1 years. So basically, post-transplant, alcohol use is really accelerated that, and really accelerated. We see that with other diseases as well, but it's quite clearly demonstrated here by the Kaplan-Meier curve on the right. And this is really important because we have limited organs. So while we are now transplanting record numbers of transplants every year in the United States, we're also adding patients to the wait list at record numbers. And so the actual gap between number of livers, organs available and the number of people that we're waitlisting is increasing, not decreasing. And sadly, about 1 out of every 5 patients that are actively listed for transplant in this country will die waiting for organs. So, like I said, we also really have to pay attention to alcohol use disorder, given its prevalence. And I tell patients right off the start, when I start talking about this, that I think of this as a chronic relapsing disease, and we need to really remove the stigma to this disease and think of it as a disease like everything else. So just as we'll talk about, we should be screening for alcoholic liver disease, we should be screening for alcohol use disorder in our patients. And I think a lot of us don't really think about this because we just think about the alcoholic liver disease. So it's defined by the DSM-5 as having at least 2 of the following things: imbibing larger amounts over a longer period than intended, persistent desire, craving, strong desire, failure to fulfill obligations, giving up important social events and or occupational activities, continuing alcohol use even when physically hazardous, and then also signs of withdrawal intolerance. So the more of these features that people have, the more severe their AUD is. And so we need to be thinking about this. So a lot of patients will say, well, how much can I be drinking? And that's hard to answer. We in general say that harmful use is for men, 3 or more drinks a day, and for women, 2 or more drinks a day. But I hate to say this, but there's an increasing amount of data out there that shows that there is no real safe amount of alcohol. I know that we all have held on to the French studies that suggested maybe some red wine every day would be good for the heart. But as our database increases, we find that there is not really a safe amount of alcohol. And there may not be actually any benefit to it at low doses like we previously have thought. The other really challenging thing here is that while there is a dose response relationship, meaning a higher dose, if you will, of alcohol will increase the risk of you developing alcoholic liver disease. The problem is that there is no clear cutoff and there is extensive individual variability, meaning that it's hard to predict for the patient in front of us. A lot of this has to do with concurrent disease such as viral hepatitis, obesity, and tobacco, including genetics, and actually having surprisingly a previous Roux-en-Y gastric bypass may triple the risk of developing alcoholic liver disease. So if everybody that drinks enough quantity-wise to develop cirrhosis, it's only about 10 to 20% of patients actually will. However, those other 80, 90% of patients certainly are at risk of developing all of the other potential complications of cirrhosis, including pancreatitis and increased risk of malignancies and diabetes and things like that. But a big teaching point here is that cessation of drinking at any point in the spectrum of alcoholic liver disease, including decompensated cirrhotics, reduces the risk of disease progression and occurrence of complications. So it's never too late to quit. Another important thing here is that women are at higher risk for developing ALD compared to men. When we control the quantity of alcohol and the body weight, women have significantly higher relative risk of developing ALD than men. And that's thought to be for several different reasons, including decreased body content, a smaller volume of distribution, and reduced activity of gastric alcohol dehydrogenase that all lead to this. And this is a big problem because women are again experiencing higher rates now, proportionate to men, of developing alcoholic liver disease. And I don't think it's unrelated to increased marketing and global acceptance from a cultural standpoint of alcohol use as well. So I think we do a very poor job in general of screening for alcohol use disorder in our clinic. I'm sure I'm biased here because every day we're seeing patients that are now decompensated and have obvious alcohol use disorder. And when we comb through prior records, knowing that this patient had been drinking for a long time, this goes missed a lot. And that's not through negligence. I think this requires a lot of attention and time to address. But I also think it's really important because this is a disease that typically presents late and is subclinical for years before patients present with decompensated alcoholic liver disease. And certainly the best opportunity to intervene is before patients reach decompensation. But of course, a lot of patients will either not be forthcoming or actually mislead their providers in terms of their alcohol use. So a nice initial screening test is how many times in the past year have you drank 5, or for men, or 4 drinks in a given setting. And if that's positive, then we can dig further. Both the NIAAA and the USPSTF recommend using the audit recommendations, which is 10 questions that are scored that do a nice job of predicting the use of the prevalence of alcohol use disorder. But the shorter version with just 3 questions can be used and then expand to the 10 questions if they're positive. So we've been using biomarkers for a long time when it comes to alcoholic liver disease, like urinary ETG, excuse me. But really the one that has really taken off recently, and I strongly recommend using, is the PEth test, or phosphatidylethanol. And essentially what this is it's a very specific reaction of a phospholipid that is formed when phosphatidylcholine reacts with ethanol in the red blood cell membrane. So we kind of refer to this as the hemoglobin A1C of alcohol tests. And it's basically got a much longer half-life of about 10 to 14 days, so we can detect alcohol use, depending on the quantity, as long as a month prior to testing. It's got very good performance from sensitivity and specificity. We generally think that there's no other false positives other than maybe recent massive blood transfusions beforehand. And this, unlike other testing, can allow us to quantify the degree of alcohol intake as well. Now, I want to emphasize, while I think this really should be used in circumstances such as patients that are now sober, and also when patients come into the hospital, with an admission that have known alcoholic liver disease, I think that's a great time to send it. I don't try to use this to quote unquote catch patients. And so when I see patients in clinic, after I get their alcohol history, I'm very forthcoming that we will be doing a PEth test today. And I explain what it is because I'm not trying to catch patients and I want to maintain a therapeutic alliance and improve alcohol use disclosure as well. And patients even will come saying that they want to be tested to kind of prove their sobriety as well. So I can't give this lecture without talking about the spectrum of ALD, and I already mentioned that it can compose mild hepatic steatosis all the way to decompensated cirrhosis. But unlike other forms of chronic liver injury, alcoholic hepatitis can present at any stage of this spectrum. So while 60 to 70% of patients may have underlying cirrhosis, a lot of patients don't. And alcoholic hepatitis can be very lethal, as we all know. I think we're pretty familiar with the definition, so I'll skip over that. But emphasize that the mortality is incredibly high, regardless of the degree of fibrosis underlying. One newer development is that a MELD score, even in the absence of underlying cirrhosis, can be used, and in fact, in recent studies has been shown to be more accurate for the diagnosis of severe alcoholic hepatitis than the discriminant function. So essentially using this to identify patients that may benefit from steroids and also have higher mortality risks, which are really quite terrifying. 30 to 50% of patients will die at 1 month if they have severe alcoholic hepatitis. And also, I can't help but say here that we really have poor therapeutic options. Of course, the most common one is being steroids. And I always think of we use steroids because we don't have better therapeutic options, excuse me. So this is not exactly new, but I can't give this lecture without talking about the STOP-AH trial, which was a large randomized 2x2 factorial design study done in the UK back in 2015 that looked at 1,100 patients that with severe alcoholic hepatitis and were randomized to either placebo, pentoxifylline, or prednisolone in some type of order. And it showed a trend towards improved 28-day survival in those with prednisolone, but that was not durable to 90 days or 1 year. And it did have increase in significant infections, which is actually the #1 cause of death in these patients. And I stopped using pentoxifylline after the study as it showed no mortality benefit. So if you are going to use steroids, which I do think is reasonable if patients don't have contraindications like sepsis or GI bleeding or AKI, we should be using the Lille score, which is a calculation based on their labs, especially looking at change of bilirubin to predict those that respond. And if patients have a Lille score that is poor, as defined as greater than 0.45, as you can see here in the Kaplan-Meier curve, we should stop their steroids because they are not responding and would only be subjective to all the risks without the benefits. So overall, this is really pretty poor outcomes. So what else is out there? So I think probably the most exciting thing on the horizon, which is still pretty far from common use and is not FDA approved, is the use of larsucosterol. So this is a phase 2A study that was published. Essentially, it's an endogenous cholesterol derivative in an IV form, administered in an IV, that reduces intracellular lipid accumulation in the liver and also decreases inflammatory mediators in the liver that's thought to have improvement in alcoholic hepatitis. So at EASL, the European Association to Study Liver Disease meeting just about 3 months ago, in a US cohort of several hundred patients, it actually showed a 58% reduction in mortality at 90 days in patients that were randomized to this drug. So this is yet to be published in full form, but the FDA gave it the green light as a therapeutic breakthrough designation. So they are planning their phase 3 study. So obviously there's a lot of hope about this, but we're still far from approving its efficacy, but it also had a good safety signal as well. Now, one of the things that we don't talk about enough, in my opinion, is nutrition. So while we use steroids all the time, I think actually addressing nutrition is much more impactful than using steroids. And basically, the reason for this is malnutrition is present in almost all of our patients that we see with severe alcoholic hepatitis, which in of itself is also associated with a poor prognosis. We really need to be quick about using tube feeds in patients that are not meeting their goals. And we really should be shooting for high caloric intake as demonstrated there. and also really emphasizing the importance of high protein intake as well, with a goal of 1.2 to 1.5 grams per kilogram per day for these patients. And that has been shown to actually reduce the risk of infection and encephalopathy. But nothing will ever compare to the importance of abstinence, which of course is challenging in this group of patients, as I said, alcohol use disorder is a chronic relapsing disorder. But compared to every other therapy that we've been talking about and will be talking about, abstinence is the most important, and that we also really need to be emphasizing with our patients. On the left are studies that show the effect of abstinence in patients that show survival, and even certainly in compensated, but even in those that have already progressed to the point of decompensation, abstinence will make a big difference. And that's been demonstrated on the left in older studies, and also in more recent studies, we see this over and over, and we see it in our clinics as well. But we're also, I think, neglecting the use of something else that's really important, and that is treating the underlying alcohol use disorder, because that is the biggest predictor of overall mortality. I really like this study from the Mayo Clinic that looked at a total of about 300 patients. On the left is a retrospective cohort, and on the right is a validation prospective study where they looked at about 300 consecutive patients admitted with severe alcoholic hepatitis for their index admission. And they found that those that did do early alcohol rehabilitation and counseling had significantly reduced risk of of hospital readmission, alcohol relapse, and about almost a 40% risk in death. I don't know, that's more than I think any prednisolone study has ever been shown to do. So how good are we? We know what to do. How good are we at doing this? The answer is pretty poorly. The other thing that we should really be emphasizing is medication-assisted treatment, especially in those that have cravings. So I would point out, again, we already talked about the huge burden of disease and mortality in this country due to alcoholic liver disease, yet we only have 3 FDA-approved medications for alcohol use disorder, and none of these medications are approved by the FDA specifically in patients that have underlying alcoholic liver disease. Specifically, disulfiram has a black box warning as it is extensively metabolized in the liver. And there's historically only been a handful of studies that have actually looked at baclofen, which is, again, not FDA approved, but baclofen's been to date the only one that had historically been studied for use of AUD in patients with underlying liver disease. Now, recently, I have seen a handful of studies, not prospectively or randomized, but retrospective studies, including this one that has looked at acamprosate in terms of its safety for using this in patients with alcoholic cirrhosis. This is a recent European study that looked at a single study, non-randomized, but looked at patients that both were used with baclofen and also acamprosate that had underlying cirrhosis. Unfortunately, there was no difference in the abstinence rate, but there was also a good safety signal in both of them. And interestingly, the acamprosate was associated with lower risk of hospital readmission than those that were on baclofen or nothing. Now, one of the really exciting things we're looking, GLP receptor agonists are being used by everybody and for every context. And interestingly, I think this is really tantalizing, and we'll see what the data shows, but there are areas of the brain that are involved in the same reward pathways that have GLA receptors as in the same areas that control some of the addiction pathways. So there are a lot of studies. In fact, there's over 9 phase 2 clinical trials looking at GLP-1 analogs for use in addiction. And that could be not just with alcohol, but also with tobacco and opioids and cocaine. Some of the initial studies in this field were mixed results, but they used the older generations of the GLP-1 receptor agonists. And now we're looking at the newer ones that are being used. There was recently a publication in Nature Communications. There was a retrospective study of a large number of patients, 84,000 that were on semaglutide for obesity, and they found that those that had alcohol use disorder had a 55% reduction. So I think that this is one of the exciting things that we're all very anxious to see more data about. So I alluded to that both. I think there's a lot of opportunity to be engaging our patients both in therapy and using MAT. How good are we at using this? And unfortunately, as you can guess, the answer is not very good at all. I really like this study, although it's a retrospective study. It was a VA-based study that looked at a very large number of veterans, 38,000 veterans that were diagnosed both with cirrhosis and alcohol use disorder within 6 months. And it looked at how many of those were then engaged in behavioral treatment. And on the left, the answer was 12% in the 6 months after their initial diagnosis. Those that got pharmacotherapy alone, or MAT, was about 0.5%. And those that got both behavioral pharmacotherapy and behavioral treatment was 1%. And interestingly, of those that got any treatment at all, there was a significant improvement in their mortality at 6 months. So we know what to do. We're just not doing it. And I went the wrong way on that slide. So historically, these are all limited treatments. And so liver transplant has been the ultimate treatment. But unfortunately, we have used the 6-month sobriety rule for a number of reasons. But of course, that's not going to help our patients with alcoholic hepatitis. Now, it's important, I think, to understand the logic of why we use the 6-month sobriety rule. Number one, there is some data that increased duration of sobriety may decrease the risk of recidivism post-transplant, and that certainly makes sense. Additionally, it did provide time to see whether the liver function could recompensate, and these patients would no longer need a transplant with sobriety. So it could help save patients from an unnecessary transplant. And it also fit the universal rule of one size fits all, that we could treat everybody equally in terms of applying the same rule to all. But unfortunately, this, I think, has a lot of holes in it. Number one, there's nothing magic that happens at 6 months. And in general, 6 months of sobriety has been shown to be a relatively poor predictor of alcohol relapse after transplant. And also, there are now data that I will present that post-transplant relapse rates are similar for those that had less or more 6 months of sobriety. I think it also encourages dishonesty. So I can't tell you how many patients I've seen that miraculously have had exactly 6 months of sobriety. And it encourages, I think, late referrals. And it does not encourage what I showed is the most important, and that is focusing on treatment of AUD. And of course, this would exclude all of our patients with alcoholic hepatitis, because by definition, those patients have drank within 2 months of their presentation. And so essentially, we could never transplant for alcoholic hepatitis. Now, most people have seen this data before, but I can't give this lecture without talking about this landmark study in 2011 in the New England Journal of Medicine. That was a French multi-center study that looked at transplanting patients with very short periods of sobriety for alcoholic hepatitis, which before there had really never been any use, or there had never been any experience in. So they had very strict protocol in terms of their criteria for whom they would consider for transplant. It had to be the first decompensating event. They had to fail corticosteroids. They couldn't have coexisting psychiatric disorders. And essentially, the group had to have, the transplant center had to have universal agreement. So of those select 26 patients that did get transplanted, they had overall much better survival at 77% at 6 months compared to those patients that were also included that were not transplanted, where only 23% survived. There were 3 patients that had relapse, but overall good survival. But the real key thing in this message, that we can glean from this, the message that we can glean, is that while we can transplant for those that have alcoholic hepatitis with very early short sobriety, they need to be very carefully selected. And so the real, I think, important thing in this study is that it was less than 2% of patients that were considered were ultimately approved and transplanted. So there's been further data that has looked at this, including the American Retrospective Accelerate AH study, which looked at 147 patients that showed good 3-year survival. That's comparable to other etiologies of liver disease. And these patients were very sick with a median MELD score of 39 and had very short sobriety. And so what we can learn from this is that of those patients that had relapse, which was a minority, any use of alcohol after a liver transplant was associated with a 3.5 times increased mortality compared to those patients that remain abstinent. And sustained use, which is defined as greater than 100 days of alcohol use after a liver transplant, was associated with a hazard ratio of 4.59 times the risk of death after a transplant. So the take-home message is that any amount of alcohol use has a significant risk to both patient and allograft after a transplant. But we know now with further data that patients that are transplanted with short sobriety have similar overall outcomes in terms of both alcohol relapse rate and patient survival rate after transplant. And of course, there's a big selection bias in this. So what does this do? This really means that we have nationally increased the rate of transplants for alcoholic hepatitis significantly. So we should really be looking at this, and it gets us back to the case that we started with. So is he a transplant candidate? Let's talk about how we decide this, because quite frankly, from what we have here, we really don't know. So what's most important? We'd probably say insight. Now, on that schematic of this patient case, we really don't have any ways of assessing his insight. And insight is a really hard thing both to define. I think everybody would define it as something different, but it's also really hard to be objective about. Now, there are a lot of questions that we ask our patients, such as when were you first made aware of a liver disease and did they quit at that time? Did they accept that alcohol was a cause? When they were told by a healthcare provider, did they stop drinking? Has it resulted in other sequelae, negative complications, including relationship or financial or professional or legal complications? Have they been sober before? Why did they feel they need to quit? When did they relapse? What were their triggers? And also, what kind of counseling have they done? And in fact, those patients that have extensively done counseling but relapsed after every one may have a higher risk of relapse because their addiction is that much worse than others that have not. So in addition to insight, I think really the way that we ought to be thinking about the risks and benefits is trying to group this into protective factors and negative factors as displayed here. Other protective factors are social support. Do they perceive negative consequences of their alcohol use? Do they make that connection? Do they have other things that they're looking forward to do in absence of drinking all day, or what they might do after a transplant? Do they have other activities that they're looking forward to doing? Or was drinking pretty much their only activity, and trying to find a substitute for that is going to be challenging? I think the negative factors I think we're most familiar with, but are there concurrent psychotic or personality disorders? Family history speaks to both genetics and observation of patterns. Did they have a diagnosis prior of alcohol dependence? Have they failed, as I mentioned, prior attempts at rehabilitation? And do they have other substance abuse and consequences of it? And also, I had mentioned, are they socially isolated? So as part of our work up here at Colorado, we have our transplant psychologist who I think might be on this lecture, and feel free to jump in and tell me how I'm wrong about this. But all of our patients with alcoholic liver disease generally see our transplant psychologist, and he or she uses a multi-method assessment models, which combine both subjective as well as objective data. And it's important to think about what are some of the variables that might be modified, could be modified, like a mood disorder, or what is more of a refractory problem like personality disorders. And so while we are using a lot of subjectivity in this, there's a number of tools that can be used to try to objectively quantify this as well. But I think really the emphasis, and I mentioned, is the importance of substance use treatment. And again, we need to be treating AUD like any other disease without the stigma. And the way that we treat it is not with transplant, but with therapy. And ideally, our patients would be engaged in at least weekly individual substance use sessions and weekly substance use groups. And this could be on an individual or group therapy that our psychologists and social workers will both make recommendations and consider dual diagnosis if there's other things like depression or other mood disorders that may be implicated in the patient's AUD. So who do we consider after all this for transplant? Well, number one, patients both need to be able and willing to engage in treatment. And a lot of patients are not, and that's frankly a non-starter. Historically, we've required inpatients to be able to leave the hospital and initiate alcohol counseling, but a lot of patients are too sick, apparently, especially those that are in the hospital with HRS and are quite ill. And we've also excluded patients that are not able to engage because we really could not assess their insight if they're unfortunately grossly encephalopathic. And of course, there's a huge need for good social support, not just to help reduce the risk of recidivism, but also being able to stay with patients after transplant and provide transportations and things like that. So because a lot of our patients, unfortunately, are too sick or too ill to do that therapy, we have developed here at Colorado a limited sobriety pathway for transplant. And essentially, these are for patients that don't either have the time because of the severity of their disease or the ability to complete their requirements prior to transplant. We do not have a sobriety time limit. We've incorporated both patients with cirrhosis and alcoholic hepatitis. And we do have a signed form where patients essentially are agreeing to complete either as much as they can before, especially after transplant, that both our social worker and our psychologist have prescribed. And also post-transplant, these patients will have frequent visits with our transplant team. They'll be agreeing to monthly PEth tests for the first year. And also recently, we're really delighted to have hired and welcomed to our team a substance use navigator that can really help with some of the heavy lifting of managing these patients. And of course, there's a lot of requirements too. And our exclusion criteria include patients that have previously had major complications of their AUD. This needs to be their first hepatic decompensating event. They must acknowledge the role of alcohol in leading to their liver disease. They can't have other major psychiatric conditions or prior relapses. And as I mentioned before, they need to be coherent in order to assess their insight. They need to have both support of their advocating hepatologist and also universal agreement by the transplant team. So how have we done so far? Thank you, Kaylee, for this. We've now transplanted 65 patients since we have incorporated this about 2+ years ago. 14 of those are still within their first year. We've kind of looked at our 1-year outcomes, and we've had 9 failures of the 65. 6 have relapsed from alcohol, 1 has developed other substance abuse, and 2 were non-compliant with our requirements. So you can argue, is that success or is that failure? And I would argue, again, we know that AUD is a chronic relapsing disease. And we know that even when we were transplanting patients with 6 months or more of sobriety, we had the relapse data that we had before. So I think that this hopefully tells us that we're on target. But I would say that this is overall a very humbling process because our ability to predict any behavior, especially on an individual basis, is really limited. So this is, of course, not the only thing that goes into whether patients are transplant candidates. I put up here this dizzying slide that shows all the different components that go into a liver transplant evaluation. So while we certainly want you to refer these patients that have indications for transplant, if patients are clearly not a transplant candidate, we're also happy to see them in our hepatology clinic. But essentially, there's a lot of other testing that goes into whether someone's a transplant candidate or not outside of their AUD assessment. So really, what we're looking for of all of these patients that are presenting with AUD and deciding whether they are transplant candidates is unfortunately a needle in a haystack. And unfortunately, there's also a lot of haystacks that we're looking in. So I think we certainly can do transplant, but it needs to be in very select patients. So what about those patients that are in the haystack and they're not the needle, or at least at the time that they are getting sick? One of the things that one of our recent graduates and new faculty members, Dr. Harding Theobald, along with Lisa Kenny at our Cedar unit here on campus, have developed in the past year is a multidisciplinary alcohol liver disease clinic with great success, I would say. So if these patients, especially those that are not suitable for transplant and are either still using or recently sober, one of the mechanisms is for follow-up and trying to help them, especially with their AUD, and connect them with therapy literally right there in our clinic, is to come to this alcohol liver clinic, which you can also refer your patients specifically to. And especially we look at this as kind of 3 months of intensive support for these patients, along with addiction medicine, and offer them MAT as appropriate, which is really, number one, used as both a supportive tool for support and monitoring and maintain rapid access to these very sick patients, as well as managing their liver disease. But also it's a selective tool. I think they have found that there's high variability from person to person in terms of what is their response to being declined for transplant and what is their willingness to engage in mental health resources. And I think we very quickly will identify those patients that are going to be engaged. And we have had success in converting some of these patients from not being candidates to candidates, or even better, coaching them and getting them to the point where they can be sober and have recompensation of their liver disease without needing a transplant. So what can our referring providers do? Well, I think hopefully quite a lot. As we already talked about, I think one of the most important things is screening for AUD and catching it early before alcoholic liver disease progresses. We already talked about the questions that you can ask to try to assess both protective factors as well as risks. And discussing AUD in a matter-of-fact way without the stigmata and treating it like a disease like it is using tools like motivational interviewing and reviewing the patients that a liver transplant does not cure alcoholic use disorder. And also documenting that when you tell a patient that, there is no safe amount of alcohol for their liver, that it also gets documented, because when we're looking through records and trying to assess if patients have so-called blown through stop signs where other providers have previously told them to drink, to stop drinking, and unfortunately they were unable, that helps us in assessing their ability to remain sober after a transplant. I think obviously it's critically important to refer to local resources for therapy and counseling and consider MAT as appropriate. And in those that do have AUD, evaluating for other concurrent chronic liver disease and also staging their disease as well. And so for those that possibly do need a liver transplant, early referrals using alcohol screens, especially PEth tests monthly and upon hospital admissions, is really important. And then also addressing other addictions, especially tobacco, as that is considered a contraindication to transplant. Unfortunately, as the liver disease progresses, we see more and more malnutrition and frailty, and trying to address nutrition issues especially. And then also we require age-appropriate cancer screening for all of our patients, so being mindful of things like mammogram and pap smears and colonoscopies. So I think a real big emphasis here needs to be that this is a disease that really needs to be treated in a multidisciplinary fashion. And I'm really happy to do this on a day-by-day basis with my peers that are displayed here. So not just my co-hepatologists and APPs and post-transplant teams, who are all excellent, but our surgeons and social workers, and I mentioned our new substance use navigator, our dietitians, psychologists, coordinators, and financial coordinators. And we could not do transplant without this. So my summary slide, it's busy because I think I've covered a lot here, but I've shown that there's an increasing burden of ALD and death in the United States, and it's the most common indication for transplant. We really need to be recognizing this early, screening for AUD, using the PEth test, and having an emphasis on directly treating patients for their AUD. We also talked about that alcohol consumption is the strongest determinant of disease progression and long-term mortality. This is a disease that can progress silently or subclinically for long periods of time. And when it does progress, these patients are often really sick and too sick to really participate in AUD treatment. So screening, because we also have relatively effective therapies, but hopefully more on the horizon. We talked about 6-month sobriety rule is inadequate as a tool to predict recidivism post-transplant. And this really does require multidisciplinary treatment of both AUD and ALD. We've shown the transplant may be appropriate for a very select group of patients with severe alcoholic hepatitis and decompensated cirrhosis, but we're still at the end of the day really limited in our ability to predict post-transplant recidivism. And with that, I think I'll take any questions, and I thank you for your time and attention. I will try to go here to the chat box and see if I can find any of these questions. And if there's not, you are also more than welcome to email me directly. One question here I see is how expensive is the PEth test for those, and usually is it covered by insurance? That's a fantastic question that I do not know. I have not heard it being denied before. I'd say that anecdotally. It is a send out lab even here. And I would say that initially when we started sending it, it was a very painful 2-week delay. And in fact, it was a problem when we had patients that were really sick in the hospital and we were waiting on a PEth test. It literally became something that determined life and death. But fortunately, a turnaround has come about much quicker nowadays. So I'm afraid I don't know the specific answer that you asked. And I'm sure it would depend on individual circumstances with insurance. Sorry, I'm just reading the next question here. Yes, Avash says we want to thank our social workers and psychologists who work with us, because these patients and circumstances are so complex. And I would say that even when we're evaluating patients right in front of us, either in clinic in the outpatient setting or in the inpatient side, it is so hard to assess these patients. And I have to say, trying to evaluate these patients over a phone call is even harder. And that's probably our biggest fear, is that we're just making such important decisions with very limited information. One of the questions are, since the phase 2b trial of the larsucosterol is excluding patients with alcoholic hepatitis whose MELD is greater than 30, do you worry about the real world applicability and if and when that is approved in the future? Absolutely, but I think a lot of these studies have been used in alcoholic hepatitis in the past. They do exclude the sickest of patients because they acknowledge that trying to prove any efficacy is going to be hardest in these patients where I think regardless of the treatment that we provide, they are either going to die or get a transplant. So proving efficacy is really hard in those with greater than a MELD of 30, as you say. And I think that, we do see a lot of moderate severity of alcoholic hepatitis as well. And I think certainly that would be the low hanging fruit for these groups, but we're not going to know about the efficacy. And that, frankly, that's going to be very hard to prove in these really sick patients. How important or meaningful is it for the referring provider or to be advocating for the patient with alcoholic hepatitis? I think it means a lot. I was on inpatient service a week and a half ago, and I got a call from a hospitalist who has called us in the past on patients and said that, for what it's worth, yes, this patient has short sobriety, but has good insights, and kind of listed off the reasons for why this patient had good insight, in addition to no other major psychiatric or addiction-based comorbidities, and had good social support. So, that was a patient that I said, yes, we should absolutely get transferred here for an urgent inpatient evaluation. So I would say that the referring provider kind of assessment makes a big difference, because one of the biggest predictors and one of the biggest challenges with these patients are they going to be invested in their well-being after transplant, especially if they do have recidivism. Then oftentimes they can disappear, stop answering our post-transplant coordinators' phone calls, and for those that are on this webinar are certainly acutely aware of. Whereas if the provider says, I'm the patient's primary care doctor or GI, and they are now making all of their clinic visits, taking all their medications, showing both compliance and insight, and engaging in all of my recommendations, that makes a big difference, because that is, essential to predict a good outcome post-transplant. All right, looking back here. Another question, we have seen a large uptick in incidental cirrhotic diagnosis in late elders in their 80s and 90s. Is your group working with these patients and treating them the same as younger patients? I would say yes. So as Avash can attest to, there's controversy, as we have debated formally in the past, about what's our upper age limit for transplant, and there's no one age cutoff. Certainly age is just a number, and there's a big variability between different patients. 70 has historically been used as a general cutoff, but we're really trying to consider patients and their biologic age, and I would say different transplant centers will view that differently. So for those that are in the 80s and 90s, sure, we can be treating in the same ways and encouraging them to engage in all the same resources that I said. But of course, they're going to have much higher mortality if they actually do have decompensated ALD, just given their decreased, usually ambulation. They're more frail and can be sarcopenic, and their ability to tolerate small complications is really marginalized as we get older. But I would say in general, as long as patients are coherent and cognitively intact, we should be treating them in exactly the same way. Oh, okay. Someone put on here, Quest lab prices a PEth test at $109 to $142. Thank you. That's very helpful. So I would imagine that that's on par with a lot of our other testing. Well, I think if there are any other questions, please feel free to directly contact us with questions, and I'm more than happy to discuss anything else. But thank you for your time and your attention.
Thanks, JP, and thanks everybody for joining. All this information is on the website, which has been sent out to you previously by email, but you can also just search online for University of Colorado Liver Transplant Webinar Series. You'll find the link and our schedule and all the information on there. Thanks again, and hope everyone has a great day.
Thank you.